conference. Our next speaker needs no introduction, or he
Wait a
should not
minute.
need.
I think he needs an introduction.
Should not need an introduction. If you don't know Dr. Lubbers, he's kind of a big name in our area. He is an EMS physician, EMS medical director. He's board certified in EMS. He works at UC. I think he's over their EMS department or something like that. But he works up there with Dr. Bill Hinckley. So phenomenal speaker, a good friend, and a generous lubber. Okay. And with that, I will turn it over to you, Dr. Lubbers.
Don't forget that last part. All right. Good morning. Actually, give me 1 second. I realized we just had a tiny bit of an issue here. Ta-da. That's a little bit better. All right. Yeah. Good morning. Thanks for hanging in there. I am the last talker before lunch, so I'm going to try to make this right. But as Floyd said, thanks for hanging out with us. We are certainly glad to be able to put this together and be able to do stuff for everybody. I, of course, have no financial conflicts of interest because this is not a paid conference, and anybody that's got one can go screw themselves. Anyway, yes. They tell you to talk about things that you are interested in. So I want to tell you about how I got interested in this particular subject. I was working as an attending in a level 1 trauma center. It is sort of a big area, or it has a fairly wide catchment area, pretty much all of a state, in fact. And when I was overnight one night, one of the EMS crews from a far off place brought in a 37-year-old patient with a gunshot wound to his neck. Now, he had been at an outside hospital for a while, so we had an idea of what was going on. But because he is a gunshot wound to the neck, it's proximal, it's around the box. So this becomes the full trauma activation. Everybody comes down, anesthesia is there, there's like nursing supervisors that show up and all that kind of stuff. They show up and the guy is brought in. He is sitting upright, he's talking, he's breathing. And trauma says, before anything else, stop, don't give your report. We want to hear manual blood pressure. And so we go through the process of getting a manual blood pressure, which actually meant we have to transfer the patient over to the bed before you get the manual blood pressure. And so, 5-6 minutes later, we finally get our manual blood pressure and it's fine. The trauma team does a basic assessment and they say, well, his airway's intact. He's got bilateral breath sounds. Everything looks good there. Abdomen is soft. He's got palpable radial pulses. They do a fast exam. They do a chest x-ray. They do an AP pelvis. And at that point they say, oh, all right, no life threats, nothing for us. Sew up the hole. Send him home, maybe put him on antibiotics, up to you. We're now about 15-20 minutes into this presentation of this patient. I look over, again, I'm the attending, I look over at the EMS crew who's still standing patiently with their tablet at the foot of the bed. And I recognize that probably their goal at that point was, well, we're probably not needed, but we got to get signatures. But I happen to say, hey, I'm sorry. Can you give us a report on this guy? They say, yeah. He said he was standing in a fair and felt this tug on his neck and suddenly collapsed. And he hasn't been able to move his arms or legs since then. What? I go up to the guy real quick. Sorry, sir, 1 second. Sir, can you move your arms or legs? Nope, trying right now. We had gone through the entire resuscitation and bad on trauma and bad on us, not only for missing that this patient had a gunshot wound to the neck and was a quadriplegic at that point, but all this could have been solved if we had just gotten the bedside report in a timely fashion, or if we had given EMS the respect that they needed in order to give that report, because it was comprehensive and it told us everything about it, including stuff that I wouldn't have even necessarily said was EMS level reporting. And God love them, they were waiting to do their best and we didn't give them that opportunity. And that made me mad. But at the same time, it's not always our fault. And by our fault, I mean the hospital's fault. We often in EMS, I'm going to include myself in that because I do work in the field, not as often as I would like to, but I do work out there. It is sometimes our fault in the field in that we don't do a good bedside report, or we don't think about a good bedside report, or we just kind of slop through it. So I initially started this about a couple of years ago, gave it at a small conference and said, this is how you are going to dominate the bedside report. You're going to take it back. We're going to grab it by the scruff of the neck. We're going to wrestle around with it. And we're going to pin it down and we're going to punch it in the back of the head until it stops squirming around. And that's what we're going to do with the bedside report. We're going to own this thing. And I gave it sort of like that. And somebody actually screenshotted this and Twittered it saying that, wow, this was a really nice, I really like this. And then somebody else the next day, followed by a bevy of others, said, toxic masculinity, blah, 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 blah. Fine. So I I kind of dumbed down the thing. I made it more politically correct. I said exactly what I wanted, what I should say, and how you should say it. And then I started reading this again a couple of days ago, getting ready for this talk. And I just decided, you know what? I don't like this either. If the other one was too much, this is way too little. Let's just say what it is that I want to say. How do you make the handover good? Or at least how do you make it not terrible? Because it's critically important. And even more so, it's not critically important maybe for us as it is for the patient. Because it's really the patient's handover. It's not EMS's job. It's not the hospital's job. I mean, it's all our jobs, but it's not our handover. We don't care one way or the other. The patient cares a lot because he's the guy that actually benefits or loses from it. And ultimately, he's the guy paying the bills. So we got to watch out for that. So how do we make our handovers not good? Well, we got to start at the beginning. We don't like your handover. Doctors, that's us. Working in the emergency department, we don't like the EMS handover. Most of the time we find out it's missing important things or it's kind of sloppy, and we just don't like it. When it's been studied, 78% of the time it didn't include, or sorry, only 78% of the time did we even hear what the patient is there for, which means 1 out of 5 times there was no complaint listed by our EMS report. Only about half the time do you include pertinent physical exam findings, and just a little more than half the time do you actually provide a description of the scene and trauma, which is deemed to be quote unquote important. If you look at it visually and you were to say, hey, I'm going to test you, paramedic student, on each of these domains about your bedside report, and you put the passing mark at 70%, you find that most of us fail most of the time. And the only thing we consistently do is give a chief complaint. And that includes important things like, again, vital signs or an assessment of the patient. Tell us what the heck is going on. So we don't really like, in the hospital, we don't really like your report. Well, fair is fair. You don't really like us either. And this has been shown time and time again, and everybody kind of knows this. EMS feels that, or EMS providers, pre-hospital providers of every shape and size, say that we don't really like the bedside report that we are giving as well. Why? Because we feel rushed. We feel like there is no focus in the room. We feel like everybody is running around doing something else and not listening to us. We're just kind of talking to the wall. Likewise, if I give a brief report that one guy likes that just has sick, not sick, basic injuries, and then vital signs, they ask, why are you not giving the full report? What's the patient's allergies? What's his mother's name? Is his mother coming? There's no standardization. And probably most concerning, there's no respect, or not a lot of respect, for the EMS provider. In that, not only does the hospital not know what the job is, but they really don't even understand kind of what we are when we bring a patient in. And that, again, is an issue as well. Sorry, I just realized that was on camera. We'll move that. And again, fair is fair. Here's the report from EMS. If 30% of the time us being jerks is a passing grade or less, you find that overall we interrupt you. We ask for information that's already been given, and then we interrupt you asking for information that you would have given in a second most of the time. And so we all fail at this. And when I initially wrote this presentation, I had lots more graphs and there was lots of evidence, and just like everybody else here, you know, it was really evidence-based, and it was academic, and it was perfect to give to a hospital administrator. And I ended up with a slide, something like this, and you could put an American flag behind it, and everybody would like it. But that's not the talk that I really wanted to give. I decided that honesty was the best policy. And so here's the way that I really feel about EMS handoffs.
I've got certain information, all right? Certain things have come to light, and, you know, has it ever occurred to you that instead of, you know, running around blaming me, you know, given the nature of all this new shit, you know, this could be a lot more complex. I mean, it's not just, it might not be just such a simple, you know?
What in God's holy name are you blathering about?
That's the EMS handoff that I really want to fix, both from the EMS side and from the Walt side. What's the problem? You guys give really great care. We all, and I'm, again, going to wrap myself in there. I'm a medical director. I work with EMS. I consider EMS to be my job. We all give really good care out here in the field. We give good care in the back of the ambulance as we're coming to the hospital. We give good care when we are transporting a patient from one hospital to another in a really difficult situation. We give really good medical care in all these places. And yet, for some reason, when we get into the hospital, more often than not, it seems like, and maybe this is just like one bad apple spoils the bunch, and it maybe doesn't happen that much, although based on the data that we saw, I bet it does. It's like we kind of forget everything. And either we don't care or we don't know how it is that we're supposed to behave in the hospital itself. Now, obviously, not everybody does this. And most of the time, probably everything is, at least lukewarm and everything is tolerable. But there's those one or two that come in as absolute stinkers, and we got to fix that. Now, I will absolutely grant that there is very little leeway given to EMS from this group of people that you see here. Now, if you look at this cat back here, he gets referred to, he was my resident. So this is Lubbers' resident. This is Lubbers' patient that's going to be on here. Likewise, this is one of the trauma residents. That was one of the trauma residents. You would say, well, that's the trauma attending's patient. That's Dr. Tucker's patient. That's or it's the ER, it's Dr. Lubbers' patient or something like that. You don't get that benefit out in the field. There's no doctor attached to it. It's not, this is Lubbers' service or Fritz's service or Hilty's service or Hinckley's service or something like that. What you get is it's the EMS. It's something that we don't really know what it is. It's just sort of out there and they bring patients to us, but it's not actually a medical service like we kind of think of it. And that's a problem. That's a big problem. And here's why. This is the House of Medicine. It looks pretty nice, right? Yeah, I'm somewhere in there. But here's where you guys get to stay. And that's not your fault. And that sucks. Because as much as I hate the t-shirt that says doing the same, paramedic doing the same thing doctors do, but at 90 miles an hour, it's not doing the same thing I do, and I don't do the same thing you do. And you don't do the same thing as a nurse, and the nurse doesn't do the same thing that you do. We all have different jobs, and we got to respect that, absolutely. But you are being asked to at least provide the same level of care or make the same decisions that I would with significantly less training, with significantly less resources in a much harder area. It is not 72 degrees and low relative humidity with good lighting outside the hospital, and you got to deal with that, whereas I don't. It's different for each person, absolutely. Now, don't feel too awful bad because as well as I said, I'm an EMS doc. I am only sort of in the House of Medicine. We're sort of connected by a breezeway, and it's not all that warm. It's pretty drafty on that side of the house, but I've at least got a space in there. And that, again, that all kind of sucks. But I think mostly it's that people don't really know what it is that EMS is supposed to be doing. And then we don't really help ourselves in that we don't always act like we're part of the House of Medicine when we show up in that short little period of time. But absolutely, EMS is the practice of medicine. If you attach the snake and the stick to your logo, that means you're going to be practicing medicine. Now, you may not practice medicine per se, but it is a practice of medicine, and you are doing a practice of medicine when you practice EMS. Absolutely. And so I'd like to empower you. I'd like to say we can't crap on EMS anymore, and everybody knows that happens. Every time I go out and ride with a paramedic company or with a fire department or anything like that, it seems like every time I come into the hospital, I'm just like, God, I can't believe you guys get treated this way every single time. And it's maybe not even something that's intentional, but it is out there. So we've all got a responsibility. The ER has a responsibility to you. You have a responsibility to the ER, and we've all got that responsibility to the patient. So let's lay out some rules about how we're going to get this handover thing, get back to brass tacks, how we're going to get this thing to actually work out. Here's Lubbers' rules for handoff. Number one, when you walk into the hospital, the patient is still your patient. There are two handoffs that have to happen. There's a physical handoff where you move the patient over onto the bed, and there is a cognitive handoff or an information handoff where you tell the receiving team about this patient. He is still your patient until both of those things have happened, and you still have to continue to care for him. Now, I'm not saying that you have to make a whole bunch of big medical decisions at that point, but you are responsible to make sure that that handoff actually occurs. Why? Because it's good for your patient. It's the thing that the patient needs, is a good handoff between you and the emergency department. If you like the Joint Commission, and I don't like the Joint Commission, but they put out stuff and people listen to them, 60 to 80% of the time, the mistake happens because of either a bad handoff or poor information relay between people in the hospital itself. And there's no reason to think that that wouldn't happen in an EMS handoff. So remember, this, just because you walk through the hospital door doesn't mean, oh, I can hand him off and it'll be okay. He is still your patient. It is your job. The best practice for you is to get this patient safely handed over to the waiting facility. Now, that doesn't have to happen the second that you walk in the door. When you walk in the door, what you should expect in the first 5 seconds is essentially silence. And what we should expect from you is to say the patient's life threat. If there is no immediate life threat that can't wait 2 minutes for the patient to get properly handed over, then fine. But if the patient has something critically ill that needs to be dealt with before you can take your time and do an appropriate handover, then you need to say that right away. As soon as you come around the door of the resuscitation room or wherever it is you're dropping the patient off, you got to say, hey, he has a critically unstable airway. We're not able to oxygenate him, or he has critical hemorrhage in his lower extremity. We've been unable to manage. He has unresolved hypotension. He has unresolved severe hypothermia. Or he's under active CPR, something like that. You have to announce the life threat, and you got about 5 seconds to say that. And that has to happen. It's your responsibility to say, we cannot give the formal handoff. We have to address this part now. Why is it your responsibility? Because you've had the guy for 45 minutes, because you've taken care of him from, London, Kentucky up to St. Elizabeth or in Covington. You've dealt with this guy, and you're the only one that knows that life threat right now. You have to tell us about it right away. If we don't hear it, then we should all assume there is no life threat, and we have all the time in the world to make this move. Now, I mentioned moves before. You have to do one, again, there's 2 moves in each one. There's the physical move, and then there's the mental move. You have to do one move at a time. Why? Because if you try to do 2 things at once, then things get dropped. Sometimes that's patience, sometimes that's information. But you do not, none of us have the ability to do 2 things at one time, as much as we might like that we multitask. You can do one part or you can do the other part, but you can't do both effectively or safely. So either do the physical move first or do the mental move first, but you got to do one at a time. And finally, when you are doing that physical move, it is fairly important, I think, for EMS to lead that. For the EMS providers who have taken care of this patient and know everything about this patient and what drips he's on and what he's got hanging where and how he's actually affixed to the cot, it is super important for you to lead the transfer. Why do we let the hospital personnel come in and start like ripping stuff off and like taking down bags and even opening up pumps sometimes and turning things off? What the hell, man? This is my stuff. Keep your damn hands off it. Look at all the places where this guy could get snagged or something pulled out. And some of this stuff is pretty important. There's one there, there's one there, there's one there, there's one there and there and there and there and there and there and there. There's all kinds of places, and nobody in the hospital knows where those places are except you, because you've taken care of them. And then who in this move is the guy that actually knows the most about the patient? It's this cat down here, and he's at the damn foot of the bed. How is he going to affect anything? EMS should be coordinating the move. It is your stuff. You have taken care of the patient. You know how he's packaged in there. You coordinate the move. You tell us what to do, and we'll be great hands, but we're not going to touch anything unless you tell us to. And also, don't be afraid to make that happen. Hey, guys, it's getting a little chaotic. This is a pretty complicated person. Let's just give us a minute. I'll help you sort this stuff out. Okay? All right. Appropriately assertive. Not a jerk, but appropriately assertive, again, for the patient, for safety. And last thing, for the love of God, there is no reason to go fast once we have identified those life threats. So for the love of God, slow down. You don't have to give this thing at warp speed. There is no prize for finishing in 30 seconds. Yeah, we're all sort of busy and you want to get back to the station or you want to get back to sleep and we want to see some other people or stuff, but you don't have to rush this. Just take it easy. You've identified the life threat when you walk through the room. And if you haven't identified that life threat, or if there is none, then there's no reason to go fast. You can take a minute and a half to get this person cognitively handed over appropriately. Nobody has to rush with it. So now you can give your bedside report. Few tips. Number one, make it easy to follow. I'm an ER doctor. I am going to follow the first thing that comes to my eye, and it's going to be really hard for me to deviate from that. But of course, that first thing that I saw was Godzilla. I did not even realize this girl was not wearing a helmet, and all the safety implications that go along with that. Unfortunately, though, the picture that we get, if we're not getting a really clear report, if we're not getting something that's easy to follow, is less like that and more like this. And if you can spot Godzilla, then God bless you. But you probably can't. There's lots of stuff not only to distract you, but it's just hard to see and to prove that he's there. There he is. So you have to lead people down the path. You have to provide something that is easy to follow, that definitively shows people the information that you want them to know. How might you do that? Well, consider standardization. The MIST is MIST or DMIST, which is demographics, start off with DE, and then MIST, mechanism of injury or medical complaint, injuries identified, signs and symptoms, which includes vital signs, and then treatments given. That is one way to do it. And the good thing about this, I use this particular thing when I am given reports. The good thing about this is that not only does it allow me, who's a receiving person, to say, okay, I know what to expect next. He told me about mechanism. Now I'm going to hear about his injuries, and he's not going to include treatments with that. That also makes sure that I, as the, as the person who's giving the report, don't miss anything or don't miss the important stuff, because this is the important stuff, at least for the EMS report. Now, you'll notice it doesn't include patient allergies. That's okay, unless they are critical allergies or something like that to something we might give them, and there's no other way to get it. You honestly don't really have to give allergies. You don't really have to do past medical history, at least in this setting. Stick with what is important, and hopefully we retain enough of that. You could get into some of these more complicated things like the S-bar. I think this is a lousy way to do it, especially for an EMS report. For God's sake, don't do the team steps thing. How are you ever going to remember that iPad? How are you going to remember those 10 different things? They don't even make sense to start with. Keep it simple. MIST, couple of letters. They're easy to identify, and everybody can do it. Now, the problem is, though, that it's not quite that simple. So in one study where we took, the study participants, 56% of the time before the intervention, the hospital retained information given by the ED people received information given by EMS. So 56% of the time, just over a coin flip about whether or not the hospital would retain these points of information. They implemented a standardized EMS reporting tool, the DMIST, as I mentioned, and that number goes to 49% of information is retained by the emergency department, which is a non-specific difference. The thrust of the paper, though, is not that MIST doesn't work or that a standardized handoff doesn't work. The thrust of the paper is actually, though, that just implementing it on an EMS side, just telling EMS providers to do a standardized report is not the thing that fixes a lot of information transfer. It's a system issue. So, standardized reporting, good. Also good, don't give it to the room. And everybody kind of knows this in communication. If you are talking to somebody's back, not only are they telling you, I don't care, but also at some point you're going to start saying, well, I guess he doesn't care. Or I'm not sure if he's even listening to me. So don't talk to somebody's back. Likewise, don't talk to the ceiling. Don't talk to that wall. And don't give the report to the patient. The patient doesn't really care. You got to find somebody in the room that really needs to know that information. And who in this messy resuscitation situation actually needs to know, makes the actual decisions about what happens. Honestly, and don't take this personally, anybody, it's that guy, not the recorder, not the nursing staff, not the patient. It's the guy that usually stands at the foot of the bed without wearing any kind of PPE because he is not actually intending to touch the patient. It's usually some sort of physician in charge in these big resuscitations. Now, if it's a nurse who is going to record it for the triage note, okay, fine. It can be that person, but pick a person. It doesn't have to be this guy. It could be the recorder for that matter. Pick him if that's what you want, if he's the guy that's listening to you. But eye contact with that guy, speak to that guy, and yes, the rest of the room should listen in. Absolutely, we should have everybody's attention, but pick one person, give the report to them. And if that person all of a sudden, looks over here, starts doing something else, stop. Say, oh, sorry, I thought you were doing something else for a second. I thought I'd give you a second to get situated. Good? Okay, good. That is a reasonable thing to do because we owe you the respect of paying attention to you and looking you in the eye and listening to what it is that you're saying while you're giving this important bedside report. It should go without saying that you should know the patient, of course, although I've had many a patient brought to me, hey, why is this guy intubated? I don't know. Okay, what's this note about a GI bleed here? You know anything about that? Nope, said he has a GI bleed. Okay. Fine. You have to know the patient. And the more critical the patient is, the more you have to know about them. And I'm sorry, it's not always going to be simple. And I can't straighten that out. This is the practice of medicine. You have to know your patient. Likewise, I think the only thing worse than 2 minutes of sort of bad information, which I can then go back and confirm, is when I get pinned down for 4 minutes of no information. we have to make it not rambling. We have to make it easy to follow, but we also have to include the stuff that is really important to the patient and leave out the stuff that's not important to the patient. You may not know who this person is, but if you went to a Yankees game at Yankee Stadium between 1951 and 2007.
At first base, number 23, Don
Mattingly. He's also a linguist and taught speech and forensics. And the thing that has made a big impression on me is one thing that he said in an interview: how do you do your job right? Well, I make it clear, I make it concise, and I make it correct. And if you follow that stuff, that is the way to give a bedside report. So before you walk into the hospital, if you're thinking about, and you should be thinking about how you're going to give this report, what would Bob Shepard do? How would he give this bedside report? Be clear, be concise, be correct. And how do you do that? Well, again, it's a standardization process, not just for EMS, but for your hospital system. This is an example. I think this is a good example. It gives you the MIST template at the top. It says we're all going to do this thing. It gives you a couple of other things like here's the rules. We're not going to move the patient before we've heard about him, that sort of stuff. But most importantly, I think, for our standpoint, is it says give EMS 30 seconds and you'll get all the information. Don't ask any questions. Don't try to move the patient. Give us 30 seconds and you'll hear everything that you need to know. And that works for all these people should be yours for 30 seconds. And if you can do that in 30 seconds, then perfect. If it takes you a couple of seconds longer, all right, you're going to lose a few folks. But you should expect 30 seconds. And if you see a back turn to you in 30 seconds, bring it up. Call them out on it. You're not wrong if you do. All right. Well, that's pretty good talk, I think. But there is one last thing I wanted to say, and Howie Mel talked about how he wanted to piss people off. I don't want to piss people off, but I do need to say this. If you come into the hospital, zip up your damn boots, tie your shoes. If you shamble in looking like Kesha at 3 a.m. after a night out at the bar, then we are left to assume that you have given Kesha level care, and nothing you say is gonna make us think differently about that. You may be the greatest paramedic in the world. You may be the love child of Floyd Miracle and Tom Beausoleil and everybody else that's been given talks today. They all got together and they produced this EMS baby that is beautiful, but if he doesn't tie his shoes and looks like a hobo, then it's not going to make any difference. And you may say, well, Lubbers, you're just pejorative there. I am not just pejorative. Here's what influences your perception of a handoff. It's not whether or not you get complete vitals. It's not whether or not you gave the correct patient demographics. The thing that has the most influence on the perception of a handoff for both EMS providers and for ED staff was whether or not you appear professional. And I didn't make that up. That's a thing that's what we find out. That's objectively measured data. People care about whether or not you have your shoes tied. And you may take that back to your agency and say, well, the hospital cares more about what I look like than if I tell them the vital signs. Yeah, the hospital does. But at the same time, if you noticed on that graph, EMS really cared more about whether they thought the hospital was professional than if they got all their information transferred over. We all care about it. At least those of us that really care about the profession and care about the care of the patient. So EMS is the practice of medicine, and you don't see anybody else walking around in the hospital with their shoes untied, or at least you shouldn't. They're probably not going to stay that way for very long. And I hate to say that you have to look the part, but you kind of got to look the part. Help yourself out in this way. If you come in with your shirt tucked in, and it may be 3 o'clock in the morning, and you may feel like hell and you may look like hell, honestly, but if you come in, tuck in your shirt, tie your shoes, and don't look like you just stumbled in off the street, then we are much more likely to give you the benefit of the doubt on something that maybe was a questionable decision. And I hate to say that it's a legal thing, but honestly, there's a legal part to this. I've been involved in at least 3 cases where it has been the perception that really, not the medical care, it's what the perception of the paramedic was that really turned it from an easy to defend case into something that there was no way we were going to win. And everybody just says, settle, 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 settle. And that sucks, but that is the way it is. And that's the way medicine works. Hence the bow tie. In the end, you're part of the team. I'm part of the team. We're all part of the team. There's one team, and there's one goal, and that is to move the patient down the field. And as long you don't have to like the people that are on your team with you, but if you follow that goal and stop purposefully trying to poop on each other, then we'll be better off. And I would say at the same time, if you're an EMS provider, as much as I would shoot this pigeon or the pigeon provider who is the pooping on you, I would say, well, why are you letting the pigeon sit on your head in the first place? Take steps to make it better yourself, and then let us know if you have problems with it, because nobody should be doing that to start off with. So that's my little bit of a rant and a spiel. EMS has a place in the house of medicine. It is the practice of medicine. Maybe it's not in the big house, but it's probably off on the wing there, if nothing else. And I'll be right there with you guys. Save me a bunk space. Anyway, that's my talk. So check out EMS Grand Rounds. That is actually where we will post any recordings that we're able to make of this conference as well, because that's where I've been doing it. So I appreciate your time and attention. It is now 12:08, and sorry, I think I was timed just a little bit long, but it's lunchtime. Floyd, is that right?
Yeah, I have something real quick before we break for lunch. We're going to resume at 1, but I'm still getting messages about CE. So curvetobed.com, there is a link for in the main menu. The link is CONED 19 certificates. We've overwhelmed Google. We've reached our max daily limit for certificates and maybe Google form submissions. So please try every few days. We will get certificates to you. It just takes time. All right. I promise we will get those certificates. If you've tried and it still doesn't work after a few days, then email me, curvetobed@gmail.com. I also want to say one quick thing. Dr. Lubbers spent a lot of his personal money to put on this free conference. Now, nothing's ever free, no matter how much we want it to be. It's free for you, but he spent some money for Zoom, and he had to increase that due to the number of people registered. So this is the only time I'm going to mention it. There is a GoFundMe link on my website, curvetobed.com, and the money will go to him. We're only trying to get enough to pay for the Zoom platform. But that is it. Do you have any questions for Dr. Lubbers before we break?
And I will say too that all this stuff, it is certainly our pleasure to be able to provide this free of charge for everybody. If everybody that's involved could donate $1, we would recoup the cost, or at least the cost that we need to recoup from, in order to be able to provide future conferences like it. So nobody's trying to make money off of this. Absolutely. And I'm not going to give you a hard sell on or anything, but if you got an extra buck, this conference is free, but it's not free to put on. If you have a buck, that would be awesome. But don't worry about it if you're in trouble or something like that, or if your hours are cut or something. So we just appreciate you guys being around. It's our pleasure to be able to present this here conference.
So I'm getting a lot of questions about the link. curvetobed.com. Click on CONED 19 in the menu, and it'll set you up. It'll take you to a GoFundMe page. All right. So that's how he's going to take the donations. We do have one question, I think. So let me go to Q&A. Someone asked, any tip on how we overcome the language barriers and different cultures when handing over?
Well, I hate to say, like, you have to kind of look like a doctor, but people are expecting to kind of sound like a doctor too, in terms of like language barrier, English versus some other. That one I don't have a great tip on, unfortunately, as best we can. In terms of making yourself sound like a doctor, or in information, or in terms that people are going to understand, honestly, I don't think that that's too big a part of it. If you can come in, I usually tell folks, all right, how would a doctor talk about, or how would a nurse theoretically talk about this patient's mental status? They might use GCS, but the GCS is usually wrong. The more complex we try to talk about stuff, the worse our information transfer gets. Like the bigger the words that we use, the less information I think we accurately hand over. So honestly, I would be just as happy if you come in and tell me in plain English what is wrong with this person, and we skip most of the medical terms. Like, that is fine. And I won't think any less of you for it. And I don't think most people would, as long as you're right. Because why? It's clear, it's concise, and it's correct. And that way there's less ambiguity. So that's my opinion on it. All right, you guys are
Excellent.
awesome. We will see you in an hour.
Thank you. I'll see you in an hour. We will kick it off at 1 p.m. with Handoff from the Resuscitation Academy. Thank you all. We'll play some good tunes in the background.